اوكي طيب. So what's the normal measurement protrusion? It's ranging and it's
دكتور يقطع
يعني generally يقطع مرة.
اي
طيب دقيقة شوي. Okay, is it okay now?
إيه الآن تمام إن شاء الله.
طيب تمام. طيب so it's يعني generally in Asian it's ranging in 70 millimeter, in the white population in the range of 20, and in African people between 22 and 24 millimeter. This is for bilateral protrusion. And unilateral, we consider it abnormal if it's more than 2 millimeter, and in such condition, workup is needed. Next slide. Okay. So we need to know, is it true proptosis or pseudoproptosis? So we have to confirm the proptosis using the exothermometry. Then we have to rule out pseudoproptosis. There is some causes of pseudoproptosis like high axial myopia or ophthalmos. Sometimes we see patients with unilateral proptosis, and it's confirmed also by exothermometer. But if we do further workup, we realize that it's high axial myopia. We can use for example, the A scan to look for the axial myopia in suspicious conditions. Also, other causes like lid retraction in unilateral or bilateral, and contralateral ptosis in the other eye can give a false impression of proptosis in the normal eye. And contralateral in ophthalmos or microphthalmos. Okay. Okay, so in etiologies, we classify the etiologies to the broad categories. So we don't miss the diseases in our mind. So we classify it into inflammatory, infectious, vascular and hemorrhagic, neoplastic and metastatic, and congenital and structural. So in history and exam, we have the 7 P's. The 7 P's, we have to add it to our routine ophthalmic assessment. So we can classify it to 3 P's in the history, which is pain, progression, and past medical history. And in the examination, we have proptosis, palpation, pulsation, and periorbital changes. These 7 P's, we have to add it, as I said, to our routine ophthalmic assessments, like the history of fever, systemic symptoms, trauma, vision loss, double vision, and in the examination, we do our routine examination, looking for, checking the visual function test with visual acuity, color vision, APD, and the remaining six-round examination and motility. So the first P is pain. So when the pain is positive in the history, this will limit the differential diagnosis to a very limited diseases. So mainly pain means the condition is mainly infectious or inflammatory. Pain is almost always there in infection. In inflammatory conditions, it's majority of cases it's painful, but some diseases may lack pain. So, for example, in idiopathic orbital inflammatory syndrome, the pain is present in 67% in the non-myocytic idiopathic form, and 81% in the myocytic form. In Wegener disease, it's ranging from 20 to 80% according to different studies. In sarcoidosis, it's mainly painless, and in IgG4 disease is mainly painless. In neoplastic, it's mainly painless. There is some exceptions for this. In some malignant tumors, like, for example, the adenoid cystic tumor of the lacrimal gland, which is a very uncommon condition. And also pain is a known feature of metastasis. Hemorrhagic, mainly it's painful, and it will be clear in the history that the patient had a hemorrhagic condition, like trauma history or history of retrobulbar or peribulbar injection. And congenital cases, it's painless. So this table shows the diseases that present with pain and sometimes with sensory loss. So as we said, mainly it's an infection. As we can see in mucormycosis, it presents also in addition to the pain with sensory loss. And inflammation, present with pain, orbital compartment syndrome due to hemorrhage. Neoplastic, as we said, adenoid cystic carcinoma and metastasis. So the second P is progression. So different conditions progress in a different way. So we can classify it into acute, subacute, and chronic. Acutely progressive orbital diseases, mainly it's infectious, and inflammations. Inflammations can also be subacute. And in the acute, we conditions like trauma, hemorrhage, lymphangioma, lymphoma, metastasis, direct carotid cavernous fistula. Subacute, mainly inflammations and metastasis. Chronic diseases, mainly thyroid orbitopathy, and specific inflammations like sarcoid and Wegener. Benign and malignant primary neoplasia, mucocele, acquired cyst, orbital varices. Some conditions present with intermittent proptosis. This can happen with idiopathic orbital inflammatory syndrome with remissions, and in lymphangioma. Lymphangioma can be exacerbated with upper respiratory tract infection. It's a classic presentation, and orbital varices. The third P is past medical history, like history of immunocompromised patients and diabetics, patients receiving chemo, steroids. This is very important in cases of suspicion of mucormycosis. Also, history of malignancy, lymphoma, and other malignancies if we suspect metastasis, thyroid disease, and smoking. As we know, smoking is an important risk factor for thyroid disease, severity and duration. And sinusitis, which can develop orbital cellulitis, Sjogren's syndrome, which can present with bilateral lacrimal glandular enlargement, and respiratory and renal dysfunction in Wegener vasculitis. In age also is an important factor, because different diseases present in different age groups. For example, in congenital cases, we have the teratoma, which is a congenital condition. Then we have the infancy and childhood conditions, starting with the dermoid, epidermoid, glioma, which presents at an average of 5 years, neuroblastoma at around 2 years. We have the rhabdomyosarcoma, which presents at an average of 6 to 7 years. We have also inflammatory conditions and vascular conditions. Then in adulthood, we have other conditions can present at the adult age, like meningioma, schwannoma, lymphoma, cavernous venous malformation, and in structural, like silent sinus syndrome, and other diseases. Also, some can classify conditions in gender predilection way. So conditions like lacrimal gland adenocystic carcinoma has a female predominance. Also, thyroid orbitopathy is known to be more in females. It's 6 times more in females. Neurofibromatosis is more in males. The fourth P is proptosis. So proptosis can be axial or non-axial. In axial proptosis, also we have to classify it into inflammatory, neoplastic, traumatic, and vascular. And inflammatory or infectious, it's mainly thyroid and cellulitis. It's the 2 most common causes. The neoplastic with axial proptosis is cavernous hemangioma, schwannoma, neurofibroma, optic nerve glioma, meningioma, and lymphoma. Traumatic like retrobulbar hemorrhage and orbital emphysema. Vascular is lymphatic malformations and venous malformations. Non-axial displacement can be categorized to down and out, like the first case here. So the lesion comes from the superior medial space. So the condition can be mucocele, fungal granuloma, neoplasia, like lymphoma, like in this patient particularly, fibrous dysplasia, dermoids, and hemangioma. Then we have down and in, like in this patient. So think what causes down and in. It's the lacrimal gland mainly. So any pathology in the lacrimal gland, like dacryoadenitis, neoplasia, like primary tumors of the lacrimal gland, or lymphoma, and dermoids are for sure. Then upward proptosis, it's mainly from a maxillary sinus lesions. It can be neoplasia, fungal granuloma, dumbbell dermoid, which is a dermoid connected from the lateral, from the temporal region through the lateral orbital wall to the orbit, and cavernous hemangioma, neurofibroma, and schwannoma. Okay, now we'll talk about the measurement of proptosis. The voice, is it clear?
اي دكتور clear.
Okay. طيب, measurement of proptosis. There is a lot of tools or ways to measure the proptosis. Some people, they look from up. It's called Nafziger test. But this way, I don't prefer it. Why? Because in such conditions, some conditions with eyelid edema and swelling, if you look from up, you can see a bulging eyelid. It can be solely secondary to the eyelid swelling, not caused by proptosis. So it's better if you want to look for proptosis without any tool, or you don't have any tool for the measuring the proptosis, better to look from down, like in this picture. There is other tools for checking proptosis, like in the Lewid exophthalmometer, but this one, it has inter-examiner variations. It's not it's difficult to be standardized. Other one called slit lamp proptometer also. طبعا the gold standard is the Hertel exophthalmometer. It's placed on the lateral orbital rim of each side. We have to put it on the lateral orbital rim without making stretching on the lateral canthus. We have to make sure that we are not stretching the lateral canthus, because if we are doing so, and in this way we are pushing the globe posteriorly, and we are having a false readings. We have to use as small of a base as possible, so that the base reading should be small as possible, and we have to record the base reading, because the exophthalmometer values changes with base reading. So for one patient, we have to keep the same base reading for every visit. So the proptosis measurement will be accurate. The measurement for the patient right eye should be determined with the examiner left eye, and vice versa. So as you are you seeing my mouse?
Yes, Doctor.
Okay. So in head thermometer, we have to put the two lines, these orange lines, in front of each other. It would be one line. Sometimes it's two orange, or sometimes one orange and one black. So we have to align it together to be one line. We have to look for the apex of the cornea and measure the measurement for proptosis. The fifth P is we have to palpate the orbital margin and look for any palpable mass, and to note its consistency, tenderness, extent, surface, and reducibility. With palpation, we can assess also the orbital tension by gently applying pressure over the closed eyelids, called ballottement, and pushing the globe into the orbit, and to compare the resistance with that of the normal eye. From this, you can know if the orbital region is compressible. The sixth P is pulsation. In arterial vascular malformation, or in cases of absence of orbital bone, you have to stick with Hertel thermometer or applanation tonometer to see the pulsating globe. You can see it moving in front of the scale of the Hertel, or pushing the tonometer. In such cases, can also auscultate with the help of the stethoscope to look for bruit, which can happen with the fistula in high flow, particularly, and arteriovenous malformations. The seventh P is the periorbital soft tissue changes. So these changes can be bony, or can be confined to lids, or conjunctival changes. So in bony changes, as you saw in Dr. Muhammad lecture, you can have a temporal fullness, which is a characteristic sign of sphenoidal wing meningioma. You will see a patient with fullness in this area, the temple, because of the expansion of the sphenoidal wing bone. It can also happen with a double dermoid, which, as we said, the dermoid situated in the temporal area with the connection in the lateral orbital wall with another part intraorbital. The lid changes that can happen with some cases of proptosis can be erythema and edema, which is signs of infection or inflammation. Lid retraction, temporal flare. Temporal flare is a pathognomonic sign of thyroid eye disease. Lid lag, also mainly for thyroid eye disease. Cafe au lait spots in your fibromatosis type 1. And spontaneous bruising can happen in some conditions like metastatic neuroblastoma, blood dysplasia, or sometimes rhabdomyosarcoma and other tumors. In conjunctival changes, you can find hemosis and injection, and this means that the condition is infectious or inflammatory. You can have salmon patch, like in this picture, which is a characteristic sign of lymphoma. You can have also subconjunctival hemorrhage in case of trauma, lymphangioma, and leukemia. The mechanism of visual loss in orbital diseases is different. It can be from just a simple refractive error, from a retrobulbar mass. This is sometimes it happens with cases like cavernous meningioma. It's a hyperopic jet, or by compression on the globe. It can give stigmatism, or it can occlude the visual axis in some cases with notice or mass. But mainly we have to rule out two important things: exposure keratopathy and optic neuropathy. The investigations in the cases of proptosis, we have a long list of workup, but we have to tailor our orders according to the condition. For example, if we have a classic presentation of orbital cellulitis, a patient presented with 1 or 2 days of painful proptosis with fever, and you have the classic signs and examination of orbital cellulitis, straightforward orbital cellulitis. You don't need all of these. You can limit your orders to CBC with differential and blood culture, and that's enough. In cases of, for example, thyroid eye disease, patients presented with inactive thyroid eye disease with a complaint for example, 3-4 months, and on examination, it's a classic thyroid disease. You just need to order the thyroid function test and sometimes with thyroid antibodies. In addition, with other investigations like the imaging and visual field. But sometimes you have cases presented with unclear etiology. In patients presenting with proptosis, for example, for 1 week or 2 weeks with some signs of inflammation, and you think this is inflammatory condition, but it's not cellulitis. So you in such case, you think, for example, about the idiopathic orbital inflammatory syndrome. In such cases, you have to order most of the investigations, because idiopathic orbital inflammatory syndrome is a diagnosis of execution. Also, you can diagnose an IgG4 related disease in cases presenting like idiopathic orbital disease, because there's no difference in presentation. We have the طبعا احنا تكلمنا عن يعني السي بي differential blood culture, urea and creatinine. It's needed for antibiotic dosing and for IV contrast for imaging. Fasting blood sugar and hemoglobin A1C is important in cases of mucormycosis suspicion, and also before starting steroids. CRP and ESR will be high in cases of specific and non-specific inflammations. You will find CRP is high in orbital cellulitis if it was ACE and lysozyme is for sarcoidosis, C-ANCA for Wegener, and P-ANCA for microscopic cholangitis. And also we have to order the IgG4, IgG total levels for diagnosis of IgG4 related disease. And ANA in case of cases of the idiopathic orbital inflammatory disease presentation, we add it to the workup list. In PPD, usually we order it for the steroid starting, because it's orbital TB is a very rare condition. The same thing can be applied for the syphilis. So the next is imaging, CT and MRI. So in CT, it's the most widely used imaging in orbit. It's widely available, fast, inexpensive, and it's easy to interpret. It has a good view of bone and calcifications, and contrast can be added to the study if we are suspecting a vascular or tumor pathology. Mainly, this is the cases that we need contrast in. But it has a poor definition of orbital apex. We have to order thin slices. It is 2 millimeter cuts in CT for orbits. As you can see, this is the two windows of CT. This is bone window. You can see the details of the bone, but the soft tissue is not clear. This is the soft tissue window. You can see the soft tissue clearly. MRI is preferable in the pediatric population to avoid the radiation exposure, which is more risky for the lens. It has a superior soft tissue visualization, and it's excellent for optic nerve and optic nerve sheath and intracranial pathology. But it has دقيقة شوي. طيب الصوت واضح؟
الآن كويس.
طيب قلنا ال MRI preferable in pediatric population to avoid radiation exposure, especially for the lens because it's the most sensitive tissue for the radiation. It has a superior soft tissue visualization, and it's excellent for optic nerve and optic nerve sheath and intracranial pathology. But it has a poor bony visualization, so it shouldn't be ordered for cases of bony pathology. And it's contraindicated with cardiac pacemakers, defibrillators, and any okay, we'll give some examples. The common causes of proptosis in children and in adults. In children, the most common causes of unilateral proptosis is orbital cellulitis. And the most common cause of benign tumors is dermolysis. And the most common cause of malignant tumor is rhabdomyosarcoma. If the condition is bilateral, it can be congenital skeletal deformity, lymphoma, leukemia, and other lymphoproliferative disorders. So in orbital the source is mainly from the paranasal sinus and particularly from the ethmoidal sinus. The frontal sinus is develops between the fifth and seventh year. So if you have a patient less than 5 years or less, 7 years, it's less likely to be frontal origin because in case of frontal, this is an urgent case, it needs an urgent drainage because it's the risk of intracranial extension. Sinus infection in children under 9 years of age are commonly caused by a single aerobic bacteria. And in adults, sinus infection develop over a longer interval, and it's more likely to be polymicrobial. And can include also anaerobic organisms. So because of that, we have a different treatment protocols. So in medical treatment, IV antibiotics, we consider for patients less than 9 years because as we said, it's a single aerobic organism. So the antibiotics can be enough to cure the case. So if the recommendation according to CAPC guideline, if the patient is less than 9 years old with isolated ethmoidal sinusitis and small, medial, or superior aortic access, this can be treated only with IV antibiotics and no need to go immediately for surgical drainage. If anything in this يعني if the patient is above 9 years old, let's say above 14, because some people they put the age of between 9 and 14 in a gray zone, plus minus. They go for surgery if the condition is severe. But in milder conditions, they treat it medically and they observe the improvement, and according to that, they plan for the next step. So, if the patient is above 9 or 14, let's say, this is ايوه لا لا طيب اوكي الحين واضح. طيب الحين اوكي كذا اتوقع. طيب صوت اوكي الحين؟
إيه الحين كويس.
طيب طيب فاحنا قلنا اذا البيشنت above 9 to 14 years, this is an indication for urgent drainage, or if the location of the subperiosteal is non-medial. So if it's superior or inferior, this is also indication for urgent drainage, even if the patient is less than 9 years old. As you can see here on the this coronal CT, you can see the subperiosteal axis. This white line, the enhanced white line, is the periosteum. So dermoid cysts present congenitally and enlarge progressively. It's most commonly presenting in the lateral brow adjacent to the frontozygomatic suture, and less often present nasally in the frontoethmoidal suture. Mainly it's 2/3 here and 1/3 here. Should be excised completely without disrupting the cyst wall, so we prevent the recurrence. CT is helpful to rule out encapsulocele if it's present nasally, and dacrylocele and vascular lesions, and especially if it's in the temporal area, if it's fixed to the bone and not freely mobile, it can be a dumpy dermoid, which is a dermoid in the temporal area with a connection through the lateral orbital wall with another part of the dermoid intra-orbital. Rhabdomyosarcoma presents usually in the age. It has a rapid onset and progression, and it has 4 types. Embryonal, which is the most common, and it has a good survival rate. Alveolar, it's the most malignant form. Pleomorphic has the best prognosis, and botryoid is a variant of embryonal type. The treatment is biopsy with surgical debulking, followed by chemo radiation. As you can see here, there is clear, large inferior dystopia with proptosis. Here, mainly you can see like a subconscious hemorrhage with bruising here in the skin side. So the presentation can be variable. This CT shows the tumor in this area, and this is MRI showing the tumor surrounding the globe. Common causes of proptosis in adults, either it's bilateral or unilateral, is thyroid orbitopathy, and followed by lymphoma and non-specific orbital inflammation. So thyroid eye disease, the disease can behave with a lipogenic or myogenic form. So the pathology can be confined only to the orbital part. We call it lipogenic, or to the extraocular muscles, and we call it myogenic subtype, or sometimes it can be mixed. Two-thirds of the cases, they have mild condition with orbital pads, as well as upper lip refraction, and specifically temporal flare. As you can see here, the temporal part of it is flaring up. This is a pathognomonic and specific sign for thyroid eye disease. One-third have more aggressive disease with rapid involvement of extraocular muscles, with periocular soft tissue condition, extreme proptosis, diplopia, or sight-threatening complications of corneal ulceration or optic neuropathy. The risk factors for the thyroid eye disease is smoking, radioactive iodine for hypothyroidism, and female gender. As you can see in these two pictures, both of them are for thyroid eye disease in this spot, and both of them they have large proptosis, but the CT you can see is different. The CT looks normal, nothing can be abnormal, but actually it's the fat, the black area is the fat cells, which is proliferated and pushing the globe anteriorly. Here it's mainly the muscles. You can see it's enlarged with index bearing. The second disease is the lymphoproliferative disorders. Can range from a low grade to a high grade. It starts with reactive lymphoid hyperplasia until high grade lymphoma. The orbital soft tissue are the most commonly involved tissues, followed by conjunctiva, and last are the legs. الصوت واضح الحين ولا لا؟
دكتور يقطع شوي، يصير بعيد بعدين يرجع.
طيب الصوت الحين أوضح؟
ممكن تحكي شو يقطع أنا عندي.
طيب والحين؟
الحين كويس.
طيب. Okay, so the lesion can affect the superior orbit or lacrimal gland. So it present with process or palpable mass. Conjunctival involvement may present with a thermal patch or conjunctivitis. Involvement of the lacrimal sac may cause epiphora or lacrimocystitis. Extraocular muscle involvement may cause proptosis or diplopia or both. Involvement of the optic nerve or vitreous may present with visual disturbance. Voice clear? Okay.
هي الحين واضح الصوت.
The third condition is idiopathic orbital inflammation. It's classified into 4 anatomical groups. First one is idiopathic pancreatitis. It's the most common subtype. The second one is idiopathic orbital myositis. And the third one is diffuse idiopathic orbital inflammation. It is infrequent. The fourth one and the rare one is the idiopathic optic perineuritis. As we can see here in the idiopathic pancreatitis, we can see swelling of the eyelid, mainly temporally near the area of the lacrimal gland with erythema. And in this MRI, we can see enhancement of the lacrimal gland with the surrounding orbital fat tissues. And the second case, the idiopathic orbital myositis, we can see there is abduction deficit here. So the affected muscle is the lateral rectus. We can see it here enlarged with enhancement in the MRI. We can see it here also enlarged. We compare it to the right side. Okay, thank you. Well done. Any questions?
يعطيك العافية. شكرا دكتور.
الله يعافيك.
If you have any questions, please write them on the chat, or you can unmute yourself and ask. دكتور, I think there's no questions.
تمام. اوكي, الله يعطيكم العافية.
يعطيك العافية. دكتور, في سؤال. What is the most common presentation of IOIS in pediatric age group, and what is the management?
The presentation is the same in adults with the symptoms and signs of inflammation, and as we said, it's according to the affected tissue involved. The most common is the lacrimal gland, so the presentation will be pancreatitis. And the second is the myositis subtype. but in pediatric, the idiopathic orbital inflammation, it has a more high percentage of bilaterality than in adults. It's around 1/3 of the cases can be bilateral in pediatric age. So we have to put this in mind in cases of bilateral presentation. We have to, as we said, we have to do a full workup to rule out all the other causes of specific inflammations. This is it's called this condition. It has you can find different names with time. People they change the name of this condition. You can find it idiopathic orbital inflammation or non-specific orbital inflammation, and in the past it was named pseudotumor. So it's non-specific orbital inflammation. So we have to rule out the specific orbital inflammations, like the Wegener, sarcoid, and others, by doing a full workup.
Yes.
And also including the IgG4, which is newly described and a new entity of inflammation. Yeah, طبعا the management of idiopathic orbital inflammation after, as we said, after the workup, is to start the patient with systemic steroid with slow tapering. Although there is some controversy in this regarding the biopsy, the classic teaching is to start systemic steroid with high dose. You shouldn't treat it with low dose, so you can have a partial improvement and recurrence. So you have to usually we use 1 milligram per kg with slow tapering course. And if there is no good improvement, or there is poor improvement, or if there is a recurrence, this will indicate the need for biopsy. Some people they prefer to do a biopsy if the involvement is in the lacrimal gland. Why? Because biopsy from the lacrimal gland, it has a low morbidity risk, and you can reach the diagnosis easily. And sometimes if you give steroid without making a diagnosis, some pathologies can be missing, like for example, lymphoma. It can respond partially to steroids. So there is some controversy in this issue, but classically it's acceptable to say to start with systemic steroid, and I will go for biopsy if there is poor response to steroid, or if there is
I see.
how common?
دكتور.
Yeah, that will be rhabdomyosarcoma. يعني generally it's more in the superior orbits, either superior temporal or superior nasal. If it happens in the inferior wall, in the inferior orbit, يعني this is a more common place for alveolar type. Generally, the most common is the embryonal, but the alveolar, if 2 years. Yeah, it can happen in 2 years. It can happen in 2 years, but it's uncommon. It's very uncommon. And commonly, it's the age of 6 to 7 years is the average years in these studies. Okay, thank you.
Very clear.
بالعافية.
الله يعافيك، شكرا لك.
توفيق إن شاء الله.